Hello, and welcome to Let's Talk Aging. My name is Gwyneth Johnson, and I'm the CEO at Second Wind Dreams. We are an organization dedicated to changing the perception of aging. Through this series, it is our goal to focus on individuals and organizations who are dedicated to changing that very same perception. Today, we are lucky enough to have with us Ian Kremer. He is Executive Director of the LEAD Coalition, but he has also been a policy advocate at the Alzheimer's Association and with the National Pension Center. Help me welcome Ian Kremer. Welcome Ian Kremer. Thank you so much for being with us today. Ian is the Executive Director of the LEAD Coalition. Ian, can you tell us about the LEAD Coalition and what your mission is?
Sure. So the LEAD Coalition, it stands for Leaders Engaged on Alzheimer's Disease, and we are a coalition of about 100 member organizations and then another 100, 120 organizations that are informal allies. They haven't officially joined the coalition, but they play well with others. And what we're all trying to do together is improve quality of life for people that are facing any form of dementia today, while we pursue the science to have fewer people have to face dementia at all in the future. So you could do that a lot of different ways. As a coalition, we focus on US federal public policy, but I don't like silos. There are a lot of good things we can do that not everyone's going to see through that public policy lens, and that's fine. And we'll collaborate with them any way we can. And everyone should see this movement from their own perspective. So we embrace that and lift all boats is our approach.
And I can attest to the fact that you do that. I participate in the meetings almost every month. I would love to say every month, but I learn something new every time I come to one of the meetings, and in some way I'm able to apply it to what we're doing here. It may not always be the federal policy, and sometimes it is that we can support that as well. But I have found every presenter that you bring on amazingly informative.
Great. I will tell you, I learn every time too. Sometimes in the middle of the meeting, live on camera with people watching, and that I think it's actually a good thing. A lot of folks wrongly assume I know everything there is to know. I know very little of it, but a good coalition brings together expertise from a lot of corners, and maybe the LEAD Coalition is a hub for some of that, for an information exchange. But if we're not all learning, then we're not doing our jobs.
Absolutely. And it's good for our brain health to learn all these new things. And it keeps us from getting stale in our ideas and our knowledge. So I'm a huge fan. What is one of the most impactful things that you have learned in working with older adults?
You know, and I see so much through the dementia lens, but I don't think this is what I'm going to say is limited at all to the experience of having dementia. There are about 1,000 memes on social media that maybe say it more eloquently, but I try very hard to focus on what people can do rather than what they can't. And it's not just about dementia. It's not even just about aging. It's a life course thing. I think we ought to look at our kids that way, look at our neighbors and our coworkers that way. There are times when we need our coworkers to be more than they are, or wish our neighbors were more than they are, or we look inward and we wish more of ourselves. But if we spend more of our energy trying to accentuate what people can do and what they're good at and what they're passionate about and what's meaningful to them, and dwell less on the negative side of that ledger, I think we all do a lot better.
I couldn't agree with you more. It's a management tenet. If you move people in the direction of their strength, your organization does better. And life is the same way. I'm never going to be a salesperson. That's just not something I can do. But I admire those who are, and they should be in that position and telling me what they need.
So if I can borrow a moment of your time, I will just relate to that. So I don't see myself as a salesperson either, but I'm a policy advocate. That's a different kind of sales.
It is.
And just straight up in terms of fundraising, I will tell you, when I spent 15 years working for a local chapter of the Alzheimer's Association, I was horrible and just felt incredibly self-conscious asking people I knew well for $20 for Memory Walk, to sponsor me on Memory Walk, or anything like that. Incredibly self-conscious. I would struggle with it. I did fine, but not well enough. I have no problem going to Congress and saying things like, give us billions of dollars for Alzheimer's and dementia research and care and services. That's sales. It's just a different kind of sales. And so I think it goes to your point about accentuating where your skills are and maybe being aware, but also willing to push your own boundaries about the things that either you do struggle with or you feel you struggle with. So I'm still not any better at asking people for $20 to sponsor me for a fundraiser, but I need to get over that a little and push my own boundaries and try a little harder and wait for them to say no rather than say it for them by not even giving them the opportunity in the first place.
Absolutely. How can organizations get involved with the LEAD Coalition?
So maybe that's not a bad segue. Organizations that want to get involved with the LEAD Coalition should look at what we already do that might be a fit, but they also shouldn't be afraid to say, we're not sure the LEAD Coalition is doing this other thing we care about or doing enough of this other thing we care about. And we can have that conversation and explore it. So I'll give you kind of a couple of examples. And I already alluded to one. Bread and butter for the LEAD Coalition. We go to Congress every year and we tell them how to spend the taxpayers' money better to serve the American people more justly around Alzheimer's disease and other forms of dementia. And that can be the scientific innovation lens, and that can be the quality of life care and support lens. It could be a lot of other things, but those are kind of two good, clear buckets of things we work on with Congress. So if other organizations want to advance the science and make sure that the federal government is doing its part in that broader mission, they're welcome aboard. But if they want to do something very different, they should still approach us. And I'll give you a practical example, and I apologize because I don't know for sure if you might be involved in this on a local or state level in Georgia or elsewhere, but there's a movement called Dementia Friendly America. And the LEAD Coalition was in on the ground floor of setting up what amounts to a national clearinghouse and backbone for it. But Dementia Friendly America is foundationally about community level, community driven decision making and action to make that individual community more dementia accessible and more dementia friendly. Okay, so that doesn't sound a lot like federal public policy. If you want me to spend the time doing it, I can tell you why I see that through a policy lens, but no one else has to for it to be a good, valuable thing to do. And as I said, the LEAD Coalition helped set this thing up and we've helped fund it. And I've been on the National Steering Committee ever since it was started, and I've recruited communities and done lots of other stuff. The most important thing I've done is bring other organizations to that table and then myself get out of the way and let them apply their knowledge of how their community works and their organization, even if it's a national organization, how that works, and apply their skills and their mission. Not try to change their mission, but apply their mission to that task of making one or more communities around this country a better place to live if you already are dealing with dementia, either diagnosed or undiagnosed, or as a family member or other supporter. And I'll just give you one concrete example of something some communities could do. A lot of this is born of the mentality of the disability rights community. So if you think about things that community has achieved, like cut curbs and electric sliding doors on public buildings, grocery stores, libraries, police stations, et cetera, those things were designed specifically for the benefit of people with mobility and sensory disabilities, but they benefit all of us. So you can do the same thing in the dementia space. You can say having financial institutions be more sensitive to the risks of financial exploitation is really important for people living with or facing dementia. It's good for all of us. I mean, none of us want to fall victim to financial exploitation. whether we have a cognitive degenerative condition or not. So I see that through a policy lens, but no one else has to. And any organization can be a part of that work in a way that fits their mission. It doesn't have to be that example. It could be a million other things.
That's wonderful. And absolutely. I see it as policy as well, but you can define community as big as you want or as small as you want. I mean,
Yeah.
it could be just you and your next door neighbor. It could be the entire country. So there really is an opportunity for every organization to get involved in some way or another.
Yep.
Are there any events or resources coming up or opportunities that you would like to share with us?
So the LEAD coalition itself, being a coalition of organizations, we don't do a lot of public facing events, but many of our member organizations do. And then again, through this policy lens, there are a lot of things that the general public should be more aware of that are coming up. And I'll just give you one example. Many people have heard about this new recently approved Alzheimer's medication. The brand name is Aduhelm, the sort of behind the scenes scientific name that many of us spent years learning how to pronounce before the brand name came out and was easier to say. That's aducanumab. So if you hear or read about aducanumab, it's the same exact thing as Aduhelm. But that new medication, which got approved by the US Food and Drug Administration about 5 weeks ago, and so now is technically available on the market for doctors to prescribe and for patients to use. There's a lot of work left to be done in the federal process of making sure that's really available to people. And one of the next steps is that CMS, that stands for the Centers for Medicare and Medicaid Services, it's the Medicare and Medicaid agency for the feds. CMS is going to embark on a process. They just announced this literally 2 days ago. They're embarking on a process where they're going to decide for whom, if anyone, Medicare will cover the cost of the drug.
Oh.
The public has an opportunity to comment, to tell CMS why this drug matters and for whom it should be available and under what circumstances. So I'll just give you a little color to this. And there have been a lot of headlines in the media about the controversy behind whether this drug should or should not have been approved, but it has been approved. Right or wrong, good or bad, it's out there. We live in a post-approval world. So the debates about whether FDA made the right decision or the wrong are interesting and important, but they're not relevant to the thing that the public has an immediate opportunity to be heard on. And that's for whom should this drug be available under Medicare coverage. So the price tag that the company that created Aduhelm has announced is $56,000 a year. Enormously expensive, well beyond the reach. If you think about any of us being able to afford anything that costs $56,000 a year, we'd all say, well, that's out of the question for me and my family, except for the most extraordinary families. But Medicare changes that equation. The vast majority of people under Medicare either will pay nothing or it'll be capped. The nature of their Medicare coverage or their supplemental coverage means it wouldn't cost them anything out of pocket, or the amount out of pocket would be limited. If it's limited, if it hits the cap, it's still a lot of money.
Yeah.
But part of what CMS has to decide is, should that drug be available to anybody with Alzheimer's or only to people whose clinicians have gotten what's called amyloid confirmation? So the thing this drug works to do is to reduce a particular protein in the brain called amyloid. A lot of people, if they just get the normal diagnostic workup from their primary care physician, they may be told they have Alzheimer's, but the physician isn't absolutely sure because they haven't looked inside that person's brain. They've asked them a bunch of memory-related questions and behavior questions and tried to judge whether they have Alzheimer's. There are certain tests that can examine those proteins and figure out if someone does or doesn't have Alzheimer's disease amyloid proteins. If you don't have it, you probably shouldn't take this drug. But CMS has to make that decision. Are they going to require people to get that testing, or are they going to trust physicians' best judgment? I can't tell people how they should feel about that. I've got my own opinions. I have a family history of Alzheimer's disease. I'm concerned about it. I know what I would tell CMS, but that's not necessarily the same answer everyone would give. And part of that's because some of those tests are very expensive and won't be covered by Medicare. So that would be private pay. People would have to scrounge together the money to get, say, a PET imaging test done that could be thousands of dollars. Or they'd have to decide they're willing to undergo a considerably less expensive lumbar puncture to get what's called cerebrospinal fluid. It's basically like an epidural, but I don't know a lot of people that want epidurals. I would advise people, get the epidural. It's not fun, but it's safe and it's effective, and it's a way to know conclusively if you do or don't have this disease. And Europeans apparently get these routinely. They're not scared of them. Americans are. I don't understand the sociology behind that. It just is. But the American public, whether they're Alzheimer's experts or not, ought to weigh in and tell CMS whether they think Medicare should cover this drug or not, based on whether CMS is going to require amyloid confirmation. That's the key term, amyloid confirmation. Do you need a test to verify you've got amyloid protein before CMS will pay for this drug called Aduhelm? So I apologize, that's kind of complicated, but the basic question I think is pretty simple. Do the American taxpayers want their dollars used for this drug based on the best judgment of physicians without amyloid confirmation, or do they want physicians to have to get amyloid confirmation with all that entails before Medicare tax dollars would be used to pay for the drug?
Fascinating. And it's something that we can all participate in, which doesn't always happen. So thank you. That's a marvelous thing to share. Our time is running a little bit short. So I wanted to ask you, how do you change the perception of aging?
So I think it goes back to that idea of focusing on what people can do rather than what they can't. And, the vast majority of people who are older adults don't have Alzheimer's disease or another form of cognitive impairment, particularly at the younger end of being an older adult. And I'm not sure I love the term older adult, because that's very much in the eye of the beholder and how you perceive yourself. But as federally defined in public policy, folks over 65, we'll call it that. Somewhere between 1 in 10 and 1 in 8 Americans over age 65 will eventually have Alzheimer's disease or another form of dementia. That doesn't mean 1 out of every 8 or 1 out of 10 65-year-olds. At 65, it's more like 1 out of every 30 or so. So it's a very small portion of that younger population of people we call older adults. By the time you get to 85 or older, somewhere between 1 out of 2 and 1 out of 3 that either have it or will have it. So even once someone has dementia beginning, they have a lot of good years with the potential for a very high quality of life. And one of the myths that I want to disabuse people of is that dementia is an all of a sudden thing, that you're fine one day and then you go to the doctor and the doctor says you have Alzheimer's disease or another cause of dementia, and suddenly you're at end stage dementia, that kind of public image of what it means to have dementia, where you completely lose all of your cognitive capacity and you're essentially in a near-death state. That is not true. That is not what dementia is. And many of your listeners will understand this, but for those that don't, the life course after diagnosis for people with dementia is typically anywhere from 8 to 20 years. But most people do not get diagnosed near the beginning of the disease. They get diagnosed after it's gotten bad enough that they or their family or their doctor are prepared to confront the changes that have been maybe visible, but maybe not rising to a level of being willing to do something about it. So they've probably had some level of impairment already for a number of years before they get to diagnosis. So think about all the things that were on the positive side of the ledger that people could do before they got a diagnosis, and all the many years ahead where they're still going to have a lot of ability, a lot of capacity to enjoy and benefit from life and to be enriching to other people's lives before that end stage. And that's partly about focusing on the positive rather than the negative, but it's also my way of encouraging people, don't be scared of the diagnosis. If you've got this, it's so much better to know what you're facing and know what you're not, so that you can then embrace the abilities you do have, sustain them as best you can, enrich them and nurture them and protect them as best you can, and also plan for the future when some of those abilities are going to begin to be compromised. But get the most out of life for as long as you can by knowing what you're facing, knowing what you're not, and knowing what you can do about what you are facing.
That's one of the most positive messages I've heard in a long time. There is so much life in aging and in dementia. And the more we embrace that, the more we can plan and ensure that our care is centered around us and not ideas of us. Well, Ian, thank you so much. I encourage everybody to look into the LEAD Coalition. Look how you can become involved in your local community and projects that the LEAD Coalition may be working on. And I look forward to talking with you soon.
Thank you. Thanks for the opportunity.
Thank you. Thank you for joining us on Let's Talk Aging. And thank you, Ian Kremer, for being part of our program today. As you have time, please check out our website. And as you're looking, pay particular attention to the Dementia Interpreters Program. It is a program that is focused on communication. We can work with you, we can train your team, and really focus on what it takes to understand communication barriers for individuals living with dementia. I look forward to talking with you. Have a great day.